Good evening, everyone, and welcome to our second webinar in the Better Billing webinar series. This one's the MBS numbers we are all missing. I'm Helene, and alongside me is Jade, my colleague, and we're the Workforce Development Officers at Westvic PHN. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. Just a little bit of our housekeeping. The majority of our webinar recordings are on our YouTube channel. You can see that in the chat box. We've got the link there if you'd like to go in there. We've also got our upcoming events on the screen, which you can register via our website, and Jade's going to pop the link in the chat for you. Just a special mention of our upcoming education dinners for GPs and practice managers in Warrnambool, Ocean Grove and Hamilton. There you can do the registrations via link in the chat. Please make note of the Westvic PHN health pathways relating to this topic. That's on the screen now. And we will supply a certificate of attendance. So if you could just take a moment to check that your full name is displayed accurately on your screen. If not, or you're unsure, just rename yourself or type your first and last name into the chat box now. This will ensure we get your certificate of attendance to you. This event is being recorded, and so if you could keep yourself on mute unless you would like to answer a question during the designated question and answer time at the end of the presentation. We do encourage interactivity and discussion, so please feel free to type questions in the chat box at any time, and we will ask them on your behalf. Your feedback is important, so if you could take the time to complete the survey, and the link to the survey will be in the chat box where you can do that at the end of the session. So our presenter for this evening is Ash van Leeuwestyn, and she is from Better Billing. Welcome, Ash, and I'll hand over to you.
Thanks, Helene. Thank you, guys. For those of you who've met me before, I'm Ash. Let me just get my slideshow going. Well, let me just go from there. And just checking that we can see that one, Helene or Jade, if you want to give me a heads up that that looks all good.
Yeah, I can see.
Beautiful. Okay. So tonight is about the numbers that we're missing in the MBS. And these might be numbers that you have no idea about tonight, and that's great. Or they might be ones that you've heard of before and you just don't really know how to use them. Or maybe you're a seasoned pro and you think, you know what, if anything, I should do more of these, or I've missed out on a few. So hopefully tonight what I can give you is as I always say with each of my presentations, is try and just take one thing away from it that you want to take back into your practice. And because there are a fair few numbers that we'll be going through tonight, and I'll show you how we can use them, and or even just mention some of the more simpler ones and go from there. So in terms of the presentation, what is Better Billing? Who is Better Billing? Who are you? So I'm Ash. I am a GP Reg, hopefully not much longer, finished my exam, so just awaiting at this point. In terms of what does Better Billing do, we're an online-based MBS education system. We've got a really great partnership with the PHN across all different parts of Australia, and we've also got other sort of partnerships kind of going on as well as letting just GPs, practice managers, practice nurses, GP registrars jump online, start the program as soon as you're ready, and start learning about the MBS. So we have both online courses and templates. Templates are starting to fade out a little bit as we get a little bit more reliant on AI, which is exciting, but great an option for you there if you are interested in using templates in your own notes, and also do one-on-one coaching in specific circumstances. So if you're someone that's, likes to do a bit of the online study themselves but needs to be a little bit more pushed, then that might be something for yourself. But have a look online. Quite recently, I've uploaded another free MBS cheat sheet. Mine has a lot of stuff on it, and it includes telehealth as well as face-to-face and phone calls, all in their equivalent, so you can see directly what one's a comparison. So that's totally free. You're very welcome to have a look on my website and get that for yourself. So tonight is about all of the numbers that we're missing. So this is a nice little pie chart of what everyone's doing. And as you can see, these numbers that I've pulled out tonight are from the national reporting of Medicare's item number use. And I've just looked at in for the state of Victoria, obviously, for this talk. We all know what 23 is. I'm obviously not going to be going through general attendance. We all know what the care plans are. I do have one coming up in December around care plans and utilising them and having them done correctly. So you're very welcome to join to that as well. But the ones that I'm going to be talking about tonight are the ones that no one is doing. So these are the numbers that I've been able to pull from the reports. Now, granted, you do have to ask for certain numbers, and from my experience with coaching and chatting with people, we're generally missing out on these sorts of numbers. So the first one is 10987, which we'll go through, which is a really important number in relation to the 715 for the Aboriginal and Torres Strait Islander Health Assessment. Then what you've got as well is the 11610, which is an ABI, if that's an option for you. We also talk a little bit tonight about whether an ABI machine is worth an investment for your practice or if it's not. The 699, which is the heart health assessment, and I will show you how I tend to do that to make it actually worthwhile. Devastatingly, the 715 was one of the lowest numbers that was completed in the 22-23 financial year, and 23-24 financial year for Victoria, and we'll go through that as well. So 7386 and some investigation stuff there that I've paired with the ABI, so your classic urine pregnancy tests. Then I've also got a bit of orthopedics with your rib fractures and pulled elbow reduction. Granted, not everyone gets many pulled elbows, but we're all often treating rib fractures or suspected rib fractures after falls. And very underutilized. Only 648 people billed for that number in the entire year. And then 4001, which is the non-directive pregnancy counselling, which we'll touch on towards the end. For a few different reasons, whether those people have not completed the Medicare training or whatnot, or they just don't know how to use it. It's quite often underutilized too. So we can have a chat with that. And just so you can be able to sort of see, so we all know what 10997 is in relation to care plans. And that was billed 500,000 times. So that will give you a bit of an idea. That's not the most popular item number. Obviously, your 2336s are going to be, but just to show you the scale of how low this is, that's given for you there. Okay, so the 715. So I did this one last week. If you haven't had a good look at it or want to have another look at it, you're very, very welcome to go into it a little bit more detail. But the 715 is great for so many reasons. So firstly, it's a great health assessment to offer for all Aboriginal and Torres Strait Islander patients that identify. It's every 9 months, not a yearly one. It's not timed. Okay, so you don't need to spend 20 minutes with the patient or 40, etc. I've got some information there about that patients can't be in hospital or an RACF. They need to be claimed by their regular GP, and can be done with the assistance of a nurse or an Aboriginal and Torres Strait Islander healthcare worker. So I won't go through too much of the bulk of that text there. I really recommend that you go and have a good look at the last time. But looking at how low this is, it's a great assessment item tool. It's financially a really good item number, so 241.85. Its co-billing abilities is great. Like you can co-bill this item number with a lot of things. Again, go and have a look at that 715 talk. So if we had a look, there was this is the 23-24 financial year, there was 10,667 715s were billed. And there is approximately 66,000 people who identify as Aboriginal or Torres Strait Islander in Victoria. And so if you figure out the math saying, okay, say they need to have this once every 9 months, that's only about 12% of that population are actually having their 715s done. So that's a really low number. So if anything, bang for your buck, great for your patient. A really easy thing that you can take back is go and have a look at your 715 numbers when you go back to clinic. When is the last time you billed it, and how was the process done? Can you make it quicker? Can you make it easier? Again, have a look at that first talk. So this is the 10987 number, and this is also extremely underutilized for a multitude of reasons. I think when I've coached GPs, regs, practice managers, it's just not really well understood, but it's there, and it's absolutely available for anyone who's had their 715 done. So once you have your assessment conducted and the assessment's done and you've billed the 715, in patients who are relevant, they are able to have their allied health referral sent off with their 715 as their sessions. They're absolutely able to get that. But you've got a follow-up item number that you can use for your nursing staff alone 10 times per year, and that's 10987. So you get about 2730 for this. And what this number is purely about the interaction of your practice nurse through a patient that's relevant to their goals. So say, for instance, you might have a type 2 diabetic patient who has had their 715 done every 9 months, and this year they're really strict. They really want to focus on stopping smoking, and so that's their biggest goal. So if your nurse is seeing them about checking in on how their progress is going, they've come into the clinic, they've got some observations if their goal might be to do with weight loss or HbA1c reduction, and they're checking their sugars, then that is an idea of this is relevant for a 10987. So in terms of this, we'll go through different ones that I have used, and you'll be able to see you'll be able to see yourself, oh, hang on, there's lots of them that I've missed here. So another great thing about this, and very unique, is that the GP does not have to see the patient face to face, but obviously retains the responsibility for the clinical activity. So you've got your nurses, they're giving them, great advice about smoking cessation, the quit line. They might be talking about how the patches work, the side effects, etc. And so that is a separate sort of number. So if, for instance, your patient also needs to see you for something separate, you can also bill a 23 on the same day. One really common question I get asked is whether I can bill a 10987 with my 715. And the answer is no. It's because the 715 needs to be completed first for you to have follow-up from the goals created from the 715. So having a look at this, things that I think of when I think of 10987 is examinations, observations. So weight loss with your patient and checking in on their weight every 2 to 3 months. That might be relevant of you seeing them or not. Education on their medications, their monitoring. So like I mentioned, their glucose checking. Generally just checking in on their clinical goals, having a chat with your nurse, asking how things are going. Prevention might have been one of their goals. So say we might have patients who have never had cervical screening or are terrified of getting a mammogram, and one of their goals might be able to actually get themselves back onto that screening, and that re-education and that constant reassurance, which might be through your nursing staff, then you're able to use this as another code. Any activity that you can see that your nurse is involved with in that 715 is relevant in here. If you yourself see the patient and your nurse is not involved, this number is not an option for you. So having a look here, I was able to sort of see what the situation was with different this was over 2 days, I think, from clinic, of what we did around the 715 and patients who had access to this 10987. And that is around, so one, I had Shingrix vaccine for a 59-year-old male, weight check on an 8-week-old baby, an implant on insertion assistance for a 17-year-old who was absolutely terrible at contraception and had horrendous menorrhagia. Then cervical screening for a 56-year-old, again, the lady who's not interested in doing prevention until now. Insertion of a Libre sensor in a diabetic man who might not have had one before and is not really great at doing it, so gets our nurse to do it. Marina insertion assistance with a 44-year-old female, again, weight check for somebody who's on Mounjaro, relevant to their 715, spirometry for their breathlessness that they've never checked on, or a DAS repeat to check in on how they're going with their mental health. So these are very common ones that I would see, and these are really good options for you to have your nurse involved, and get them to be involved in their goal checking, and as a result you've got a 10987 on option. Obviously, for some people who might not have a lot of nursing staff available, I totally understand, but this does not need to be, these are not timed, okay? So once again, if it is a quick weight check, it's a check-in on how you're going with the smokes. You know, have you booked in that cervical screening? That's absolutely relevant, and they are totally fine to be used for 10987. So have a look. If anything, I really recommend that you have a look and go through your books in the last week if you can, and if there's any patients who have an active 715 and you think, I've never ever used that number, I can guarantee you there'll be things there. You just need to have a look and have a think about it. So 699, and the 699 is the heart health assessment, and everyone always says to me, why would you bother? And I totally understand, but there's a few different ways that I use a 699 or a heart health assessment to be able to sort of be useful. For one, is useful, but also a good use of time versus billing rate. So it's $82.90. So it's the same as your more than 20-minute consult. You have to also spend 20 minutes with the patient on this health assessment. Okay. So for a lot of people, they will kind of say, oh, why would I sort of do it? I'm already doing something else. I've got a private rate of 120, 130, whatever it might be. It works out to be financially better for me. Absolutely. But there is one way that I tend to use this. So let's go through the 699 itself and what Medicare wants, how it needs to be done, in order for us to know how to use it properly. So 48,000 people billed a 699 in Victoria last financial year, so not too bad, but still was quite low on the scheme of things. So this health assessment can be done for anybody who's over 30 years of age. Depending on their background, 30 is quite young. I tend to see this in that group of, 50 plus. I'll explain to you why when I get a bit further, that this is the group that tends to predominantly have that assessment done with myself. From a Medicare point of view, what they're asking is that, one, you need to document your consent. So you need to say to the patient, yes, happy, absolutely, to go ahead and have this assessment. You need to take a basic patient history. So has there been any chest pain? Is there any intense family history of, really early STEMIs and early death? What's the situation we're going on with here? A basic exam, which as Medicare saying needs to have at least a blood pressure done, and you also need to have a cholesterol level documented, mentioned, etc. There needs to be, you need to initiate intervention or referral. Now, intervention doesn't mean that they have to go on a statin or do anything like that. It can be, I want you to start increasing your veggie intake. I really want you to start doing 20 minutes of walking a day like we thought about doing 5 years ago. They're your interventions you can. Referrals, if somebody is, really high risk and you think you need to see a cardiologist, then absolutely relevant, or a dietitian, or a exercise physiologist. Whatever referrals you think are relevant, they are fine. Management plan, so you need to say, okay, well, we're going to check this in a year's time, or we're going to, you're quite low risk, so at this stage we would check it, in 2 years' time, or I want you to come back to talk about your weight loss, etc. So have a bit of a plan there. And preventative health advice, so again, stop smoking, moving, weight loss, etc. Now, I want to mention as well, last talk, I actually said a 699. I think I had said it was every 2 years, and I want to fully claim that that is absolutely wrong, and it is yearly. And I'm going to blame my postpartum brain because I just had a baby. So I absolutely apologize for that. And I hope you all got the email. But yes, it is a yearly health assessment. Okay, so just to be wary, that's the situation that we've got here. So, Ash, how do you document it? You've got templates online. What do you do, etc.? I'm a massive fan of Lyrebird or AI, Heidi Health, whatever you want to do. Totally fine. I love it. It's great, and I have also made a template in Lyrebird for 699s if I'm completing them myself. So if you've got your phone, you're very welcome to scan that QR code. And it will take you to my template. If you're using Lyrebird, it will take you to my template to access in the community component of Lyrebird. So if you use it, you're very welcome to use my template. Be careful, you might want to try and play around with it a little bit yourself, because the way I speak may not be the way you speak, etc. So you're very welcome to have a look at that. But if you love a good template that's in text and it's right there and it's going to tell you exactly what you need to say and how to say it, this one on the left, you're very welcome to use. So this one I have condensed because the Heart Foundation one is fantastic, but it's like 3 or 4 pages. And when I'm going through my notes and I'm talking to somebody about them, I don't really want to be going back and forth to the template. I find it a little bit clunky and it's like typing a Word document. So I put this in my text of my note. It's very clear that I'm doing a 699 and it's very clear that I've spent more than 20 minutes, etc., whatever the time might be. So in terms of what the heart health guidelines are saying and how they recommend a 699, they like to know about risk factors. So hypertension, diabetic, microalbuminuria, familial hyperlipidemia, AF, left ventricular hypertrophy, mental illness basis, a cardiovascular risk percentage. Okay, so adding that into your 699 is absolutely paramount. And most of us with best practice is now starting to push us into the new guidelines, which needs a little bit more clicking. But still, you can absolutely do it in your notes and that will come up there. And then explaining to them what their risk is. So, okay, you're a low risk or you're high risk or you're an annoying moderate risk, and I'm going to send you for coronary calcium score, whatever it might be, and explaining what that means. Going through their family history, their medical history, getting their BMI, smoking status, and drinking status. And I personally like to do that and fill it in with my BP software, just because it's there and I like it to be that way. Discuss exercise. What are you doing? How are you doing it? Your observations, which again, I input into BP, and then your pathology findings. So for me, it's always lipids and a HbA1c. In terms of these are the requirements of your 699. So you really can't bill a 699 if you don't have a recent up-to-date lipids or HbA1c. Now, there's no specific mention as to how long can it be. Could it be last week? Absolutely. Could it be 3 years ago? Probably not. My personal rule is if it is a younger or less than 3 months old blood, I'm happy to use it for a 699. However, if it isn't, then you need to start thinking about, okay, I might use this 699 later down the track. And then often I'll give them a patient handout. You can order them for free from the Heart Foundation. They send it to your rooms and it gives them the piece of paper that you need to give them as the handout. And then chats about medication follow-up and what the patient says. Oh yeah, I'm going to start smoking. I'm going to not start smoking. Yeah, hopefully not. I'm going to start walking again. I want to cut my alcohol down by half, whatever it might be. Okay. So templates are so important, because at the end of the day, it's great if you're billing this, but if you're not documenting it correctly, you're opening yourself up for a world of hurt when it comes to audits. Okay, so if anything, spend time on thinking, okay, this is how I should do it, but also get yourself or get your practice ready with getting a really nice foolproof template. So, Ash, why would I bother with a 699? It's so long. It's so, tedious. What's the point? I can do it in another way. Okay, so this is how I tend to do it. And it's always co-billed with something else. I don't think there's ever been a time where I have billed a 699 on its own because I would be annoyed. So obviously this is a bulk billed health assessment. Okay, so you can't be privately billing for this one. So hence I use it in my co-billing numbers. So for myself, I will, if I'm doing a care plan, so it might be a care plan around something separate. So say for instance, I might have a patient who has, long-term radiculopathy, and they need to see physio and exercise physiologist, and that's what their care plan is about. And in that patient, I might say they're a 55-year-old female, and all of a sudden I think, okay, well, I have recently done your lipids, or I have recently done your HbA1c. Let's also look at your assessment of your cardiovascular risk percentage. Also, you can have this done with other things. So if you see on my side there, they might have a nursing appointment where I go, okay, they're going to have a care plan done, and then they're going to have an ABI done, because I'm big on ABIs at the moment. And I'm also going to get my nurse to maybe do a DAS21 if they're getting a mental health care plan. So this doesn't need to all happen in the one appointments, but all of those numbers together are absolutely billable. You can absolutely put these together being co-billed, okay? And or in this case, it actually will be split, because you need to put the time for the 699. So say, for instance, let's make it simple with my radiculopathy patient. They've had their care plan and they've just come over and spent 45 minutes with my nurse, and now they're going to spend 20 minutes with me in their appointment. The nurse can also help accumulate that sort of time with you. However, your appointment with yourself needs to be around 20 minutes with that 699. Okay. So for myself, they might have all the paperwork done from the care plan. My nurse might have done an ABI, but then I will do the component of the 699. And that will be where I go through my template and I go, we haven't had blood pressure issues. I know we had issues with that protein in your urine, a few years ago, etc. So that is the only time I tend to use a 699. Be wary, and I mean be wary because it does happen to everybody, is 699 can be troublesome. And the reason why, in most of the cases, it will say that you cannot use another health assessment number for these patients. So say, for instance, you've used it on a patient who is 80, and then all of a sudden you've gone, oh, hang on, there's the over 70s, my geriatric assessment that I could have done, or over 75, why have I done a 699? And unfortunately, it's one of those things where if you've billed it, you can't really take it back. So obviously, if it came down to a health assessment, doing an older age health assessment, those guys are going to be paying much more for the time than your 699. So in a weird way, I kind of think of it as a consolation prize. So it's my backup if I can't find something else that this patient is relevantly able to use. So be wary as well for that group between the 40 to 49s and those at risk of chronic disease and those at risk of type 2 diabetes, because those guys have access to your health assessments, okay? And 699 is not the best one to use for them because you have these other options. Another group of patients as well is those with intellectual disability. So they might absolutely be needing a heart health assessment. However, they're able to do it through the traditional health assessments, as they're a group that's able to be that we can do a health assessment on. Okay, so have a look at it, have a look at the patient. I always say if they're within that sort of 50 to 70s range, I start thinking, okay, this is my 699 range. Okay, so have a look and see about it yourself. So a mention for investigations. So in terms of investigations, I'm not going to go through pregnancy tests because everybody knows, but the number of missed pregnancy tests I even have done myself, and I like to think I don't miss things, but even I have missed things. And as a female GP, I see a lot of pregnant women, or I think I'm pregnant women. And so be wary of your 73806. It's always there. It's absolutely billable. Don't forget it. Even though, yes, it might be little and only, sort of $6-7, this talk is literally called Small, Mighty and Lost, because these all add up. Okay. So we're going to talk about the ABI, or the ankle brachial index. But before I do, just a special mention, obviously, for the HbA1cs. So there's two numbers that you can access, getting your nursing staff to help you out with. Those HbA1cs are through the point of care system, so that you can have a look into how much they cost. Some practices already do them, which is great. Try and do the maths yourself, whether this is something that's worth it or not. And if it isn't, go down nutritional pathology route. But if it's something you want to do, then absolutely have a look. So if anything, a mention for that. So let's get into the ankle brachial index, or the ABI. So is it worth it for my practice? quite recently, the practice that I'm at, we have got an ABI machine. And we were kind of like, is this going to be worth it? Oh, look, we'll give it a trial. And we all trialed it and thought, oh, this is shiny and new. And then I started to particularly focus on ABIs and educate nursing staff about how to find patients that are relevant to have ABIs. So for myself, how I figured this out is I see an average 26 patients per day. That's how many I tend to see. And there was I would say on average can get about 4 ABIs per day. So that's about 246.80 for that. With the practice taking approximately 30% give or take, it takes about an average of 70 days to pay for itself. Okay, so that is just me as one little solo individual. So if you have a practice, in our particular practice, we have 15 GPs. So it would not take us 70 days to pay off the ABI machine if I was a practice owner or a practice manager. So do the maths, have a look, because I don't know about you guys, but the high risk for somebody who should be considered for an ABI is nearly 85% of my patients. So the little sticker here on the right-hand side gives you an idea as to who is high risk. So anybody who is diabetic, anyone who's a smoker, anyone who's over 50 years of age, is anyone who is hypertensive or have a history of being hypertensive, obese patients, high cholesterol history, if there's family history of peripheral artery disease, or if they're symptomatic, they're saying I'm getting leg pain. This is, I don't know. There is a lot of options. And my recommendation is just making a really small little, laminated little thing that sits on the bottom of your nurse's computer. And it's in red, and it says, can this person have an ABI, question mark. And it gives them a few different risk factors, pretty similar to this one here. And if they can, then they'll go, okay, they might bring it up to us and say, hey, I've got so-and-so in here for an ABI. You're still 10 minutes behind. I have a little bit of play here. Do you want me to do an ABI? And the answer is generally yes. So that is a great option. The machine is, like I said, about $5,000. It needs to be one that actually produces the graph as per Medicare's requirements. So if you're doing one like the old school with the Doppler and yep, okay, that's the blood pressure there and that's this blood pressure here and doing them, no, it actually has to have a proper printout. If it says, oh, it's $200, it's probably not Medicare compliant. It needs to be the ones with the printout or put into the patient notes, or it needs to be in there and being able to pass on if they need to go somewhere like vascular surgery. Okay, so have a think about it for yourself and do the maths and see, is an ABI actually worth it for yourself? So how another way that I wanted to show you as well is how on earth, Ash, do you find patients for an ABI? So there's a few different things. I will personally look at my books maybe a week to 2 weeks in advance. In terms of how I'm generally booked about 4 to 6 weeks in advance. So I normally am quite full, so I'll be able to see, okay, what's the situation? And so for me, it's either alerting my nurses to, hey, I'm going to add in an ABI during that time, and adding it into their schedule. Another really good option is, not that I'm sponsored or anything by them, is Cubico is a really good option if you guys are interested and have the subscription. They can really help you find patients that could benefit from an ABI, and also the 699. It does a pretty good job of that too. So if you have that software, have a look, have a play. Otherwise, good old-fashioned looking at your patient's notes and going, yeah, that would be a really good person to see and have an ABI is a really good way of doing it, and has not failed me too much. So so having a look at this schedule, you can see here, so you've got myself in this panel, and then on the right-hand side is my nursing staff and what they might be doing at the same time. So say they've got a separate patient, they've got Mary Sample that's kind of going on over there. And then I've got Mark's sample in the morning, so he's not really relevant at this point. Then I've got Mary who's come in for her care plan review, and then you can see here I've got Annie at 9:40 who's getting a 715, and Annie is a patient who absolutely would benefit from an ABI, and so I will add that on with my nursing staff to be able to do that for me during their 715. If you feel like your nursing staff are already so under the pump and it's impossible, I mean, it's all about sort of give and take. If I feel like I've got the best nursing staff ever, and nothing is a problem, and they tend to be able to do an ABI for me within 5 minutes, and so that's really helpful. And I don't mind taking over from the 715 if that hasn't been completed, and just sort of working together as that team. Then you'll be able to see, okay, I've got Max at 10 a.m. and he is getting his 732, so his care plan review. And his wife, Diane, is straight after. And I see, okay, I'm chatting in with Max, and then my nursing staff at 10:20 are doing the review for me. And they're also doing an ABI because Max can also have an ABI while I'm in with Diane. So if anything, it doesn't take too long to just go through your books. I do it literally probably in about 10-15 minutes and cover 2 weeks in that time. And the difference that you will notice in your billings is can be quite substantial. So give it a try. If it doesn't work for you, all good. But if it does, you're welcome. So one of the last ones that I'm going to sort of focus on in depth is the 4001, or the non-directive counselling related to pregnancy. So this on the left-hand side is what Medicare says is non-directive counselling, and this is what it means. And this is the service that involves with the, what's it about? And non-directive counselling is essentially about helping and supporting a patient to make their own decision. So it needs to be 20 minutes or longer. So the 4001 number is time-based. The GP needs to have completed the Medicare training. So there is a training that you can do through the RACGP, from my understanding, where you just put in 4001 in the GP learning component and it pops up, and it will tell Medicare that this GP is now 4001 compliant. They're fine, and they kind of go through a relatively quick course about what is non-directive counselling and how does this work. So the patient themselves has to have either be currently pregnant or have been pregnant within the last 12 months. And this can be a pregnancy that went to plan and they have now had a baby. This can be a pregnancy that ended in a termination, a pregnancy that ended in a miscarriage, a pregnancy that ended in adoption, however that might be. So anything to do with a woman who is currently pregnant or been pregnant in the last year. So different things that I commonly will use 4001 for. So current decision on an outcome of pregnancy, discussing or completing a termination of pregnancy, considering pregnancy again, decisions on trying after miscarriage in relation to the first pregnancy and the trauma that they might have been going through during that, contraception after pregnancy, NIPT use, what's the point, what do I do, what's the point of using it, and letting the patient make their decision, a trisomy finding and NIPT, and discussions of next step. The biggest thing here is anything around pregnancy is fine. It's about talking to the patient to get them to make their own decision. So this isn't about you saying you really need to take folate and that is absolutely what you should be doing. And they go, okay, no problem. This is a little bit more complex, emotional support in order for a patient to make their decision. So let's have a little bit of a look at a patient. So all of my, most of my education is all about making fake patients that we all get reminded of. And then that way it sticks in our brain. So this is Marnie, who's a 27-year-old female. And you've known Marnie and her family since she's moved at 10 years old. So she's been your patient for 17 years. And she's had a long-term history of an eating disorder with 2 previous admissions, but she's been stable for the last 18 months. And she's got a planned appointment for checking in on her observations for her weight, her height, BMI, her OBS, for just heart rate, etc., just to check that she's actually well. And she commences the appointment as planned. There's good observation, there's stable weight. She's going great with the psychologist. Everything looks great. Then at about 7 minutes in, she says she has a feeling she might be pregnant. And after a urine pregnancy test that you give her and then bill for later, she goes and does that in the bathroom and says, yes, I am pregnant. And then you discuss her plan moving forward. So how does this billing situation work? So in terms of the consult time, you've spent 7 minutes in on an eating disorder and observations, and that was the point of your initial consultation. And so say you spend 7 minutes on that, and then you send 21 minutes because you need to spend 20 minutes for a 4001. So this is just an option. You don't have to do this. On the discussion of pregnancy and next steps. What are the options? What would she like to do? And your billing options, 2 different things. So first, if you go for over the 20 minutes, like I've done in this example here, say in this case, I'd be charging a 23 privately for the 7 minutes with her discussing an eating disorder, and a 4001, which is the bulk bill component. So I'd be split billing this, okay, and mentioning the time that I've spent between both. Now, 4001, okay, so it's great, it's useful if it's split, or quite often I will not use it on its own because you can have a look at the rebate there, more than 20 minutes, and that's not really adding up. So say if you spent less than 20 minutes and Marnie says, no, I definitely want to have a termination of pregnancy, or I would really like to proceed. So all of a sudden this can become an antenatal patient, which is absolutely able to be split again. So you 7 minutes that you've spent on an eating disorder and observations, that would be a 23 private with an antenatal code of 16500, okay, which is your classic antenatal code. A lot of people will say, oh, you can't do the antenatal code with a general attendance because they don't go together. And you're right if it's all about antenatal care, but in this case, we're focusing on something that is irrelevant from the pregnancy and was pre-existing. So this is not something that has occurred during the pregnancy or related to her pregnancy care. And as a result, you're able to split this code, okay? Last slide that I have for tonight is just a bit of missed orthopedics, rib fracture management, $41.65 each attendance. It goes with your 23. It just gets slapped on top. Is a really great option. We all see fractures, rib fractures, especially if you're in the nursing home, or you've seen geriatric patients, or falls, post falls, admissions, etc. And just have a think about it. If you go, oh, hang on, I remember Ash said something about rib fractures, just search it, and it's absolutely usable for us as GPs. Another one, a friend mentioned this that I need to mention, is about the close reduction of the elbow, of a pull, pull the elbow. It's a decent amount, 191.35. Personally, have not had one. But I'm sure quite a lot of our GPs here would have, and think, oh, that was an entire item number, and that's substantially better than a general attendance. So if anything, that's just a one-off to mention, and know that they exist, and you're very welcome to have a look and try use them for yourself. So I believe this is my last slide. The references are here. You're very welcome to have a look at anything. You're very welcome, as usual, to ask me any questions that you might have. So my website is just on the main page there, so betterbilling.com.au. You can put a contact form in and ask anything after the fact, and say, hey, I wanted to find out about XYZ. And I'm very happy to chat MBS pretty much all the time. Is there any questions we wanted to go through, Helene?
Yes, there is. Can 699 build with attendance item, since BP doesn't allow putting 699 with attendance item?
It can't. You're very right. So 699 cannot be billed with an attendance item, which is why in my slide, you would see that I only ever use it with other co-billing items like a care plan, mental health care plan, or investigations. So you're quite right. BP has done us a solid and said you can't do it because you can't.
Thank you. What's the difference between 16500 and 4001?
16500, so 16500 and 4001. Yeah. So the first code is the antenatal code, and that's only about using it quite often as care of pregnancy. So say, for instance, if you have got a patient that is pregnant and they're on their antenatal schedule and they're 28 weeks pregnant and they're having this baby and everything's going to plan, that is where the antenatal code is relevant. The 4001, there's nothing non-directive that I need to discuss with that patient. There's no they're adamant they're having this baby, they know about what's happening and their plan. So the 4001 is about how you are counseling a patient. So if you need to have a chat with someone and help them make a decision as their next steps, then that's where 4001 is relevant. But you do not need to do that management style with a normal antenatal attendance.
Thank you. Do you need imaging? Do you need imaging to confirm the rib fracture, or is a clinical diagnosis adequate?
Clinical diagnosis is adequate.
And I guess the next question, how would you diagnose rib fracture?
Yeah.
Would
so clinical
management, yeah.
Yeah, all clinical, based off your physical examination history, observations. I mean, if you have an X-ray, great, how fantastic, but quite often they're missed on X-ray as well. So clinically is absolutely more than fine because you're managing them as such.
What management needs to be done for rib fracture? If you just...
What was that one?
Is it what MX needs to be done for rib fracture?
I mean, it's mostly about pain relief, assuring that they're not, going down the path of, is this turning into a brewing pneumonia? Can they breathe, etc. It's about conservation, conservative management. So we're not sending these are not for the patients who are going down the road with a flail chest or anything like that. These are just your classic geriatric patients with a fall that have broken their ribs and they need pain relief and whether they need oxygen, etc.
Okay, I don't have any more questions. There is a few minutes, so if you want any questions, pop them in the chat box now. I'll just remind you about the evaluation survey. It won't pop up after the event, so if you could scan that, click on that now and fill that in. We do have some comments coming through. Great talk as usual, Ashley. Always enjoy your talks. And we've got another one, I believe, in third one coming up in a couple of weeks.
Pre-Christmas care plans.
What's this one? Antenatal counselling ? Sorry, didn't think I heard it properly.
I think that they were asking about where they can get the antenatal, the 4001 counselling information. Where do you get the training? Yeah. It's directly through Medicare, but it's facilitated through the RACGP. So if you're a college member, you can search GP Learning on and put 4001 the code in, or non-directive pregnancy counselling, and it will pop up. It's a free course. You can do it within a few hours and it's completely done. If you're with ACRM, I do not currently have the answer and I'm sorry for not knowing, but I would check that your college would probably have their own equivalent.
Excellent. I'll just take this opportunity. Thank you once again for a great, brilliant presentation, Ashley. We look forward to your next one. And participants, don't forget, Ashley's very welcome. If you want to email her or anything, if you've got any questions, please do so. And we'll see you again in a couple of weeks. Bye, everyone.